So welcome to our final crash course series. This is the Psychiatry part 3 of the series, taught by Dr. Sophie. If you look on the top right hand side of the slide, that's the link to our Instagram page, so please do follow it, and then you'll get all the updates on our sessions coming up. And then on the bottom left is our email, so if you have any questions about anything, feel free to get in touch with us. And then this is the link to the polls for today, so I'll give you a minute just to log it in, and I'll make sure I post it in the chat for anyone else who joined a bit late. We'll give you maybe 30 more seconds and then hand over to you, Sophie.
Cool. Right, hopefully everybody has managed to have a chance to scan the QR code. So yeah, my name is Sophie. I'm currently an F1 working in acute medicine, but my first job was in psychiatry. So I'm hoping I've learned a few useful things there that I can hopefully teach you guys today. I'm going to turn my camera off because my Wi-Fi can be a bit dodgy. So if there are any issues with the connection, if you just pop it in the chat, and then hopefully Anaya and I can sort it out. So today's session is going to be on dementia and delirium. So we're going to cover our different types of dementia. We'll be looking at Alzheimer's, we'll be looking at vascular dementia, Lewy body and frontotemporal dementia. We'll then move on to think a little bit about the medication that we use for dementia, and then finally we'll wrap up with touching on delirium and how it is that delirium differs from dementia. So obviously this has kind of got an overlap with some of our neurology and some of our geriatrics stuff as well, but in psychiatry there's still sort of a lot of dementia that is seen. So if we start with question 1 for today's session then. So you're a 5th year medical student and you're revising elderly care medicine for your final exams. You begin reading the chapter on dementia. Which of the following headlines best summarises the pathophysiology of Alzheimer's disease? So I'll just give a few minutes for you to read that through and make your selection. Okay, perfect. I'll stop that one there. So the correct answer to that question was C, increased formation and reduced clearance of amyloid beta peptide. So in Alzheimer's disease, what we basically have is a gene mutation in our amyloid precursor protein. And so because we've got this gene mutation, we have an abnormal version of this protein that is subsequently created. Now, amyloid precursor protein it's an important membrane protein, and we find it in lots of different tissues, and it's concentrated in the synapses of neurons, where it acts as a cell surface receptor, and it's also used in synapse formation. And when we have this sort of abnormal version of our amyloid precursor protein, it, as the name suggests, affects the amount of amyloid peptide that we are creating. So we have increased formation and reduced clearance of our amyloid beta peptide. And where we've got this excess amyloid beta peptide, we end up getting progressive neuronal damage. We have the formation of neurofibrillary tangles and amyloid plaques, and we generally lose some of the neurotransmitter acetylcholine. And this process can basically happen to like all of the neurons in the brain. However, some of the areas that are more commonly affected are the hippocampus, amygdala, temporal neocortex, and the subcortical nuclei. So we've just got a picture there sort of explaining some of that too. Quite a complex pathophysiology, but I think it's just knowing that those neurofibrillary tangles is what's going on with our Alzheimer's disease. It's quite important finals knowledge. So what do we actually see in terms of symptoms in Alzheimer's disease then? Well, there's a variety of symptoms. So we have amnesia, which is probably the most commonly known one, where we start becoming more forgetful. We have aphasia, which is difficulty with finding words. Agnosia, where patients are unable to interpret sensations and hence they can't really recognize things. We have apraxia, which is an inability to perform certain actions. And we see frontal executive loss. So this is basically where patients are unable to manage their own thoughts, emotions, and actions. What we can also see is patients become quite anxious or withdrawn. And if they were somebody who their pre-morbid personality was already quite anxious, then this is exacerbated. And what it's important to note with all of these symptoms is that they're sort of slow onset, gradual changes that happen. So this isn't something that happens overnight. This is something that's sort of happening over several weeks and months that we get this gradual decline. So, question 2. You are a final year medical student sat in on a geriatrics clinic. A 78-year-old gentleman with a diagnosis of vascular dementia is next to be seen. Before the patient enters the room, the consultant asks you to look through his notes and identify which risk factors for vascular dementia are present. So the presence of which of the following would increase the risk of vascular dementia? And again, I'll just give you guys a little bit of time to make your selections on that one. For those who have just joined us, there is a link in the chat to the polls, so you can click on that and then start making your choices.
I'm just getting it into the chat now. My laptop's having a bit of a time.
Sorry.
We'll be there. For the next question, it will be there.
Cool. Okay then. So the correct answer there, which I think people were able to identify, which is great, is B, hypertension, smoking, and diabetes. So what is actually happening in vascular dementia then? Well, it's basically where we have focal disease occurring secondary to thrombotic or embolic occlusions. So simply put, we're basically having incidents that are stopping blood flow to the brain, and this results in ischemia and impaired function of that area of the brain. So there are 3 sort of common ways in which this can happen. So we might have multiple cortical infarcts. So this is basically where somebody is having multiple strokes. They might have a single infarct, but it hits a part of the brain which has, a big impact upon functioning. Or it might be small vessel disease, which is where we sort of got furring up of those vessels. And so we've got decreased blood getting to that area. So although it's not complete occlusion, we're still having decreased blood and therefore some level of ischemia and level of impaired functioning. So some of the common areas of the brain that are associated in vascular dementia are the white matter of the cerebral hemispheres and the deep grey nuclei, in particular the striatum and thalamus. So because of what we've mentioned, these patients, they're basically having strokes, and these strokes are also impacting the actual neurological function and memory aspect of their brain. So we see stroke-like symptoms. We see a very sudden onset because it's a vascular issue. We see our movement problems as well as our thinking problems, and we can also see mood changes. And whereas with Alzheimer's, we spoke about how it was a slow, gradual onset and decline in sort of functioning, with vascular dementia, we actually see a step-like progression of symptoms. And that's because we're sort of having one insult, which is obviously decreasing functioning, followed by another insult, which will cause further decreased functioning. So there's a slightly different pattern in how it might present in patients, as well as having a slightly different set of symptoms. So when we think about our risk factors and when we compare these with vascular dementia and Alzheimer's disease, we tend to see 2 different kind of pictures. So in vascular dementia, it's men who are at greater risk of developing this. If you're of Japanese or Caribbean ethnicity, that's also a risk factor. And then, as identified in our question earlier, things like hypertension, smoking, and diabetes are all risk factors. And of course, as with sort of most things in medicine, if there's family history, that's also a risk factor for somebody developing it. So when we compare this to Alzheimer's, so with Alzheimer's, the older you get, the more likely you are to develop it. It's more commonly seen in women rather than men, and more commonly seen in people of Caucasian ethnicity. Again, family history is relevant. Alzheimer's can commonly be seen in Down syndrome or people with an apolipoprotein E4 variant. And if there's a history of depression, head injury, poor sleep, or low education in life, then these are all risk factors that have been identified as placing you at increased risk of developing Alzheimer's. Question number 3 for today's session is: you are a final year medical student on your GP placement. Your next patient is a 70-year-old male who's been brought in by his wife, and his wife says that for the past couple of months he's been increasingly unsteady on his feet, in addition to struggling with his memory. When completing your systems review, she also tells you she's noticed he has become incontinent of urine, and she says that this urine isn't foul-smelling and doesn't contain blood. His only past medical history that you can see is hypertension. So based upon this picture, what is your most likely diagnosis for this man? And again, I'll just let some time for the answers. Okay, perfect. We'll stop that one there then. So the correct answer, which again was identified, is E, normal pressure hydrocephalus. So what is normal pressure hydrocephalus then? Well, it's a triad of dementia, gait disturbance, and urinary incontinence. And it basically arises because we have impedance to our cerebral spinal fluid flow. And from where we've got some sort of blockage, it causes raised intracranial pressure and ventricular dilation. And from where we have the raised ICP and the dilation of the ventricles, we basically get parts of the brain that get pressed upon. So we see pressure on the frontal lobe, which is what results in dementia, pressure on the cortical center for the bladder and bowel, which results in our incontinence, and we also get pressure on the leg fibers of the cortex, leading to our gait instability. So with these patients, it can be, quite satisfying, because actually if we can reduce some of this, if we can, restore flow and reduce the pressure within the cranium, then we can see quite positive outcomes. So by placing in a CSF shunt, we can quite quickly get reversal of some of these symptoms. So normal pressure hydrocephalus is kind of one condition to be aware of, where we can see a combination of cognitive issues and also movement disorders. And another condition which perhaps sometimes people might get confused with our normal pressure hydrocephalus is our Lewy body dementia, which is another disease where we have a combination of motor and cognitive issues. So in Lewy body dementia, it's basically characterized by alpha-synuclein deposits within the brainstem and neocortex. And these alpha-synuclein deposits, which as you can see is a mouthful to say, are basically known as Lewy bodies, hence the name. And we see Lewy body dementia quite commonly in patients with Parkinson's disease, because in Parkinson's disease, we're seeing the formation of Lewy bodies within the basal ganglia. So obviously there is risk of those Lewy bodies being formed in other areas of the brain, resulting in Lewy body dementia. Thinking about our symptoms for Lewy body dementia, we can often see fluctuating levels of confusion. In comparison to our vascular dementia and our Alzheimer's disease, one of the key standout features of Lewy body dementia is we can get visual hallucinations. And because, as we've said, there's a link between Lewy body dementia and Parkinson's disease, we see our Parkinson's-like symptoms. So we have our bradykinesia, we have our rigidity, we can have a bit of a pill-rolling tremor. We can also find that patients have sleep disturbance, repeated falls, syncope, and autonomic disturbances. And although we said there's a link between patients with Parkinson's disease and Lewy body dementia, it's still important to be able to determine whether a patient who has Parkinson's disease and starts to have memory issues, whether those memory issues are due to Lewy body dementia or whether they've just been unfortunate enough to develop another form of dementia. And the way in which this is commonly done is that we look at the timing of onset of symptoms. So if a patient has started to have symptoms of dementia within 12 months of also developing Parkinsonian symptoms, then that means a diagnosis of Lewy body dementia is more likely. If, however, there has been a longer period of time between the two, then that's when we start to think that actually there might be two separate disease processes going on here. So question 4 for tonight's session. Again, you're a final year student on your GP placement and you're once again sat in on clinic. Your next patient is a 57-year-old woman who's recently been diagnosed with frontotemporal dementia. She is accompanied by her daughter, who has lots of questions about her mother's recent diagnosis and is unimpressed by the treatment they received in the memory clinic, which is where the diagnosis was made. The patient's daughter tells you she has no confidence in the diagnosis and thinks it's far more likely that her mother actually has Alzheimer's disease, as there is a strong family history of this. Which of the following features in her mother's presentation would make a diagnosis of frontotemporal disease more likely? Okay, fantastic. So the correct answer to that one is D, inappropriate or impulsive behaviour. So this could be things such as a person being particularly selfish or unsympathetic, maybe starting to neglect their personal hygiene, overeating, or loss of motivation, sorry. So it's basically just behaviour that seems very different to what the patient previously was like. So with our frontotemporal dementia, as the name suggests, we basically have atrophy of the frontal and temporal lobes. So we mentioned earlier how Alzheimer's could basically affect the entirety of the brain, although it did have some predilection for some areas of the brain. Whereas with our frontotemporal dementia, we're just seeing atrophy and damage of our frontal and temporal lobes. We don't see plaque formation in frontotemporal dementia in the same way that we do in Alzheimer's disease, but what we can see is something called spongy vacuolization. So this is basically where we have the formation of vacuoles within or adjacent to cells. And we also see inclusion bodies, and this is basically sort of clumps of protein that is associated with neurodegenerative disease. And these clumps of protein are often found within the cytoplasm or within the nucleus of neurons. There are lots of different symptoms that we can see with our frontotemporal dementia, but some of the key things that I'll just pick out from this list is firstly, the onset. So frontotemporal dementia tends to happen in our younger patients in comparison to the other forms of dementia that we've mentioned this evening. It's that, impulsive behaviour that we've already touched upon, and that big change in personality that's kind of the standout characteristic of this kind of dementia. There's a couple of subtypes actually of frontotemporal dementia to be aware of. So we've got our frontal variant, and this is the variant that affects behaviour and personality more, as obviously our frontal lobe is the part of the brain responsible for this. So obviously if we've got atrophy there, that's where we would expect to see changes. And then we've also got our progressive non-fluent aphasia, which describes a patient with frontotemporal dementia who has kind of lost the ability to speak and find words. And then we've got our semantic variant, which is a patient whose ability to use and understand language has been impacted. And sometimes our progressive non-fluent aphasia and our semantic subtypes both come under the umbrella of primary progressive aphasia. So I always found that there was a lot of different language that was used to talk about the subtypes of frontotemporal dementia. So I just thought I'd cover both bases of the different terms that I've seen used. So that's a little bit upon frontotemporal dementia. If we now move on to another question. So you're now an F1 working in ED, and your next patient is a 62-year-old male who's been admitted due to having a fall. He tells you that he's recently been concerned about his memory and has noticed he can't really remember things in the same way he once could. As a result, he confesses to you that he's started taking donepezil, which is a medication his partner takes for her memory. Which one of the following classes does this drug belong to? Any guesses? Then we can just pop them in on the poll. And if not, we can just move on. Okay. So the correct answer to this one was A, acetylcholine esterase inhibitors. So if we move on to part 2 of this kind of scenario, given that your patient has told you that his partner has been prescribed donepezil, which form of dementia does she not have? So we've got Alzheimer's, Lewy body, or frontotemporal. Okay. And the correct answer to that second part of the question is C, frontotemporal dementia. So let's think about our medication in dementia then. So as with most conditions in medicine, when we're thinking about treatment, we can break it down into our non-pharmacological and our pharmacological treatment. So our non-pharmacological treatment for patients with any of our forms of dementia really is making sure that they keep mentally and physically fit. And there can also be a place for CBT. So we've mentioned how with some of our forms of dementia, we can see changes sort of in personality or in interaction and changes in anxiousness and becoming more withdrawn. So in those situations, CBT can sometimes be helpful. The mainstay of our treatment in dementia, however, is our pharmacological treatment. So if we just work our way through each of our dementias. So if we've got somebody who's got mild or moderate Alzheimer's disease, then we're going to give them an anticholinesterase or an acetylcholinesterase inhibitor. It's the same name to describe the same class of, different name to describe the same class of drug. And the common ones that we see are donepezil, galantamine, or rivastigmine. And how our acetylcholine inhibitors work is, as the name suggests, they basically inhibit the cholinesterase enzyme from breaking down acetylcholine and therefore increasing the level and duration of neurotransmitter action. So as we mentioned in our Alzheimer's disease, we know that acetylcholine is related to the pathophysiology. So by preventing the breakdown of that neurotransmitter, we can increase the neurotransmitter action happening across our presynaptic and postsynaptic neuron. If we've got someone who perhaps has more severe Alzheimer's disease, or they are unable to tolerate our acetylcholinesterase inhibitors, perhaps the side effects are too much for them, or there's some sort of contraindication, then we can think about using memantine, which is a different class of medication, and this one is a glutamate antagonist. With our Lewy body dementia, again, we can think about using our acetylcholinesterase inhibitors. So donepezil or rivastigmine tend to be your first line, but you can think about using galantamine again if for some reason the patient is unable to tolerate donepezil or rivastigmine. In vascular dementia, we don't really tend to use our acetylcholinesterase inhibitors unless the patient, as well as having vascular dementia, has another form of dementia too. And that's basically because, you know, as we mentioned earlier, the pathophysiology of vascular disease is to do with ischemia and death of neurons within an area of the brain. So actually increasing the amount of acetylcholine that's firing around between those neurons isn't really going to make a difference because it's not the acetylcholine system that is responsible for the pathophysiology that we're seeing in vascular dementia. And likewise, in frontotemporal dementia, we are never going to offer our acetylcholinesterase inhibitors. And that's because our frontotemporal dementia is not affecting nerves within that communication system. So giving this medication would just have no impact upon their symptoms and quality of life. As with any medication that we're giving a patient, it's always important to be aware of potential side effects that they may get with that in order to be able to educate them properly. So some common side effects that we can see with this class of drugs is headache, nausea, vomiting, dizziness, and loss of appetite. So if we move away from our medication then, next question is, you've got an 83-year-old woman, Mrs. Tanner, who has a history of type 2 diabetes and hypercholesterolemia, and she's found wandering in her neighbour's driveway. When her neighbour tries to talk to her, she insists that she was at her daughter's house. She's very restless, agitated, and warm to touch. Mrs. Tanner last saw her daughter 2 days ago when her daughter came to pick up the grandchildren, and she was completely fine. Mrs. Tanner is recently widowed and lives alone. She's independent of ADLs and usually looks after her grandchildren after school, helping them with their homework. What is likely to be the underlying cause of her confusion? So we've got A, depression, B, delirium, C, vascular dementia, D, Alzheimer's dementia, or E, Lewy body dementia. Just give a few more seconds for any more answers for this one. So the correct answer, which was again successfully identified, is B, delirium. So what is delirium? Well, it's an acute onset, confused state with fluctuating consciousness. We see an inability to sustain attention. There's usually an underlying treatable cause, and it is brief and reversible. We can classify delirium as hypoactive, hyperactive, normal active, or mixed. So we've spoken about some of the symptoms of dementia, and we can see that actually in some ways there is a bit of an overlap with some of the symptoms that we see in delirium. So in delirium we see our memory disturbance, we can see disorientation, mood change, and poor attention. In delirium we also have reversal of sleep-wake cycle. We can have hallucinations as well. And we talked about how we can categorize delirium into hypo, normal active, and mixed delirium. So some of our symptoms that would be more specific to our hyperactive delirium are restlessness, agitation, aggression, and wandering. And with hypoactive, it's lethargy, slowness with everyday tasks, excessive sleeping, and inattention. So although delirium and dementia are both conditions that affect memory and sort of cognitive processes, there are several differences that can help us decide what is going on. The first to look at is onset. So delirium, we have very acute onset, whereas dementia is more insidious. It comes on gradually. With delirium, we kind of see this fluctuating picture where one moment patients might be really confused and then the next moment they might seem all right. Whereas with dementia, that confusion and cognitive difficulty is progressive. So although patients might have good days and bad days, generally we're seeing a decline in function. With delirium, it happens because we've got impaired functioning of neurons, and dementia, as we've already mentioned, is due to death of neurons. Delirious patients, their speech might be quite incoherent, whereas in dementia, we find it's more to do with word finding difficulty, and that's the way in which difficulties in speech manifest itself. Delirious patients have very poor awareness of what's going on, whereas patients with dementia, their awareness can be unchanged. And actually, particularly with something like Alzheimer's disease, it's this unchanged awareness that can be quite distressing for patients, as particularly in the early stages, they're aware of the fact that they know that their brain isn't really working in the same way that it was before, and that can obviously be very worrying and frightening for them. Whereas patients who are delirious really don't have any idea as to what's going on. Attention, as we've mentioned, fluctuates in delirium but tends to be preserved in dementia. Delirium, any sort of memory loss that might happen with that tends to be global, whereas with dementia, it's selective things that patients have difficulty remembering. And finally, when it comes to sleep, in delirium, we see frequent disruption of sleep. We can see reversal of our sleep-wake cycle. So patients are awake at 3 a.m. in the morning, but sleeping at the middle of the day. Whereas with dementia, it's more likely you have fragmented sleep. So you might find that you wake up several times during the night, for example. When we think about delirium, there are a couple of scoring systems that we can use if we suspect that a patient might be delirious. So the first is our CAM score, where we either need to have a patient with acute onset fluctuating cause, or we need to have a patient with inattention. And then alongside either criteria A or B, we also need to see disorganized thinking and an altered level of consciousness. And so you can see how Mrs. Tanner, the lady in the stem of our question, is meeting this criteria. We can also use the 4AT in terms of a screening system for delirium. So a score of more than 4 suggests that delirium might be present, and the way in which we can score more than 4 is if there is an obvious abnormality in alertness, that automatically gives you 4 points. If there is an acute change or fluctuating state in terms of cognition or mental function, then again, that's going to give you a score of 4. And then we can also add up a couple of points if patients are unable to remember their age, date of birth, place, and current year. So if they make 1 mistake, they get 1 point. If they make 2 or more mistakes, then they get 2 points. And finally, if when asked to name the months in the year backwards from December, if a patient is only able to do less than 7 months, they get 1 point. And if they can't even do 7 months or they're untestable, then they get 2 points. So thinking a little bit more about delirium then, but with a slightly different case scenario. You are a medical student on your geriatrics placement. You're on ward round and you've just seen a patient who was diagnosed with delirium. The consultant decides to start quizzing you on what may have caused delirium in this patient. So the patient is an 83-year-old woman, and she was admitted the day before with a fall, following a 3-day history of fever, productive cough, and shortness of breath. She spent around 8 hours on the floor before her carer found her, and during this time she was unable to eat, drink, or take her daily medication. Her only past medical history of note is breast cancer and hypertension. Since being in hospital, she's complained of feeling sore on the right-hand side of her body and has been given regular cocodamol to help with this. Which of the following is unlikely to have contributed to this patient developing delirium? So it's the factor that is unlikely to have contributed to delirium that we're looking for here. And again, I'll just give 30 seconds for answers to come in on the poll. Okay. And the correct answer there was B, uncontrolled blood pressure. So we can see that it's quite likely that the patient would have been dehydrated and, she's not been able to drink for 8 hours. It sounds like she's got some sort of infection going on. She's, got fever, productive cough and shortness of breath. It's, obvious that she's in pain. She's complained of feeling sore since being in hospital. And I think it's also fair to assume that this woman could also be constipated, given the fact that she's been provided with regular co-codamol, a common side effect of which is constipation. So when we're thinking about delirium, there are a number of causes that might result in a patient becoming delirious. And these can be quite nicely remembered with the acronym PINCH-ME. So that's standing for pain, infection, nutrition, constipation, hydration, medication. So this is either referring to a patient being on lots of different medication or having recently had one of their drugs stopped or any changes made to their medication. And finally, environment. So obviously, hospital is a very disorientating place to be if you're a patient. And so that in itself can actually trigger somebody to develop delirium. So there's some of our causes. And then we've also got risk factors that just place you at a higher chance of developing delirium. And these are things such as increasing age, frailty, a background of dementia or having other comorbidities, and then if you are immobile or already have a hearing or visual impairment. When we've got patients who are delirious, obviously we want to investigate them. And so commonly what will be done is bloods, so the ones listed on the screen. We might also think about doing an ABG if we've got a patient who is acutely confused, as obviously hypoxia can result in acute confusion. Again, glucose, urine dipstick, ECG and a post-void urine tend to be done. And then some other tests that might be done depending upon the patient's presentation include things such as chest x-ray. So if we think that it's a chest infection resulting in their confusion, abdominal x-ray if we're worried about constipation. And again, if there's been sort of an acute change in a patient's level of consciousness or confusion, then we always worry about sort of bleeds on the brain. And so that's where a CT head might come in. Our final question for tonight's session then. So you are the F1 on call overnight and are having a very busy shift when you're bleeped by one of the nurses on the old age ward. She tells you that they have a confused female patient who keeps trying to leave her bed and wander off the ward, as she doesn't appear to understand where she is or retain any of the information given to her. She's not aggressive or distressed, but she is taking up a lot of the nurse's time. The patient is new to the nurse bleeping you, and she can't find the patient's notes, so is unable to say what the patient's past medical history is. What is your management plan in the first instance? A. Prescribe 2.5 milligrams of haloperidol as per the hospital's policy for managing agitated patients. B. Tell the nurse that this isn't your problem and she should only bleep you with sick patients. C. Advise one-to-one nursing. D. Prescribe a milligram of lorazepam, as although the hospital policy says to use haloperidol, you're not sure if the patient has Parkinson's disease. Or E. Give a stat dose of memantine. Again, just a few more seconds for any more answers. Okay, we can wrap that one up there. So, the correct answer to this one is C. And we will talk a little bit through why that is. So, when we're thinking about the management of delirium, number one is prevention. Obviously, if we can prevent a patient getting delirious, this is the best case scenario. So ways in which we can do this is make sure the patient is looked after by familiar people, avoid frequently moving them from bay to bay, provide appropriate lighting, have a clock and calendar so the patient can orientate themselves, and encourage regular visits from family and friends. And these are all things that are going to help sort of ground the patient and make them aware of where they are. We want to make sure they're getting good sleep and ensure hydration and nutrition. And then if there is, of course, any underlying infection, then we want to treat that. And if there's immobility or sensory impairment, it's thinking about steps that we can take to support their patient with the additional needs. Then it's thinking about treating the underlying cause. So as mentioned, if it's infection, antibiotics. If it's constipation, then laxatives. If it is dehydration, then obviously thinking about IV fluids if the patient is unable to take things in orally. And then finally, if despite the fact that we've tried to prevent the delirium and despite the fact that we are currently treating the underlying cause from the delirium, if the patient still is agitated, then we need to think about how we can control their behaviour. So first line, we want to go for something that is non-pharmacological. So we want to encourage one-to-one nursing. So this is where there's a healthcare assistant or a nurse who's just responsible for sitting with that patient, encouraging them to stay in bed, orientating them to where they are, and just helping to sort of soothe any distress. If, however, this isn't adequate, which it frequently can be, then that's when we start to think about our pharmacological treatment. So this is important when the patient poses a risk to themselves or others, or if they've got very distressing symptoms. That's when we're going to start thinking about what drugs we can use to manage this. So it will kind of depend upon hospital policy as to which drug they like to use. I know where I work, for example, that lorazepam is the drug of choice to help with agitated patients, but in other places it can be things like haloperidol. The thing that we really want to watch out for, however, is if you're working somewhere where haloperidol is the go-to drug, then we want to make sure that we're not using that on patients who have a history of Parkinson's, as obviously that is going to exacerbate their Parkinson's symptoms. So in these patients, it'll be more appropriate to use something like quetiapine, for example. So thank you all so much for listening this evening. I know it was a little bit of a shorter session this time round, but we probably focused on some more specific topics. But if there are any questions, feel free to pop it in the chat. And we've got the QR code for the feedback form on the right-hand side there. So once you filled that out, you will get access to the slides. And as Naya said, this will also be going up on YouTube. Thank you.
Thank you so much, Sophie. Also, with the feedback, even if you're watching on YouTube, please do fill it in. We keep the link open for a very long time because we know most of you watch on YouTube now. And it's really helpful to get all of your opinions. But yeah, thank you very much. And thanks to everyone who came tonight as well.